Kia ora everyone and welcome to this Goodfellow webinar on conversations on alcohol with older patients. My name is Dr. Grace Lee. I'm a general practitioner and today I have the pleasure of talking to John McMenamin, who is a general practitioner in Whanganui.
Thank you, Grace, and kia ora koutou, everybody. Welcome to this evening's presentation. So tonight we're talking about alcohol in clinical consultations, and this is kind of a follow-up of the last webinar that I did, which was around screening for alcohol, and this is more case finding within the clinical consultation and looking at how we have these conversations that can arise out of a clinical context. So we're looking at how we can relate alcohol to the patient's agenda, assessing alcohol within the patient's health problems. We're just touching on change talk that works, and I want to mention a model called the Tacky Tacky motivational framework model. Part of the driver for looking at alcohol within clinical consultations comes from the 2016 New Zealand Health, Work and Retirement longitudinal study, which is a study of New Zealand people over age 50, over 4,000 respondents, and part of the study looked at the alcohol use. Not surprising, the results there, 83% current drinkers, so we would kind of be expecting that, so 17% lifetime or current abstainers. Very high prevalence of hazardous drinking, between 35 and 40%, and 10% of older drinkers that were classified as non-hazardous, so thought not to be hazardous because of the tools that we're using, commonly the Audit C, which is the tool that asks the quantity, frequency and binge drinking questions, have been identified as hazardous because of health-related risk. So that's part of the reason why it's important for us to be thinking about alcohol within a clinical context. Almost 50% of older New Zealand men hazardous drinkers. So we know that there is concern around young people's alcohol use, but in particular in New Zealand, we need to be turning our attention to the alcohol use amongst older people, and particularly because this is the group in which clinical conditions are more likely. It's good to remind ourselves that brief intervention does reduce alcohol risk or harm. So those are interventions that we do as general practitioners. There's a lot of evidence now. The Cochrane review has looked at 69 trials, over 33,000 participants, and has come up with this conclusion: brief interventions do reduce alcohol consumption, hazardous, harmful drinking compared to minimal or no intervention. And brief interventions is part of change talk that I'll be just touching on a little bit tonight. We know that brief interventions do mean different things to different people. The key component of a brief intervention, in fact, is not so much the particular structure of how it's done, although that can be important, but it's about the fact that there is therapeutic use of empathic understanding. And the authors of Motivation to Viewing Approach, William Miller and Steve Rolnick, which approach has been around now since the mid-1980s, talk very much about the stage of change, the way in which we use that to encourage change within people, but that it is done within an empathic style. And so the types of questions that we ask need to reflect that. So we can have a lot of confidence that if we raise alcohol, talking about it from an empathic viewpoint is going to encourage change. Just to mention the Tacky Tacky, my book, so I've got a reference there, and it's a very easy book to find. You've just Google Tacky Tacky Mai. It's a book that was originally developed about 4 years ago around motivation to viewing for Māori, but it's a framework that is very, very useful in general practice, particularly on helping us understand what change talk is about. And in that change talk, it talks about the OARS, which is an acronym around open questions, the use of affirmation around a person's responses, reflective listening where a person really feels listened to, and summarizing. And it talks about summarizing what somebody has said to you in a way that I really like. It talks about it as giving a koha back to the patient. So it's like listening to what they say. I've heard what you say, I'm now summarizing and giving it back to you, and we are going to work on this together. So this is a great book, a really useful read for anybody wanting to update their knowledge around motivation reviewing, but particularly within a framework that will work not just for Māori, but will also work within a general practice context, giving us a framework for all of our patients. And currently we're working with the Health Promotion Agency on developing a set of electronic training tools that will be based on this Tacky Tacky My approach. So I'm not talking any further about that tonight, only just to mention some of the kinds of questions that might be asked. What I'd like to look at is a little bit more when we're talking about alcohol and long-term conditions. How confident can we be around the evidence that says alcohol is related to these conditions? So if we are talking, and I've just listed four types of clinical scenarios that we'll be engaged with: hypertension, mental health, gout, and medication use. And want to look at what sits behind that in terms of the evidence that gives us confidence that it is very appropriate for us to raise this subject, and then talk a little bit about how we might raise that. And I'd like to start with a case. I've got a case for each of these four cases. So Mr. A, 55-year-old European man who attends for follow-up of lab tests updating his cardiovascular risk, so kind of fairly standard consultation for us. We've been monitoring this man, and his blood pressure is varying a little bit into the mild hypertensive range at 150, 160, 95, 100 at home readings. And he's got a cardiovascular risk calculated around 6%. So we're asking him some questions about his alcohol use, and this would be just standard questions that we would be asking in this context, just to raise a little bit of understanding around alcohol use. So we're asking the Audit C questions. So quantity, he drinks 5 drinks most days, 5 to 6 days a week, and maybe he drinks 8 to 10 drinks once a week. So this would be a not uncommon picture for us. He's drinking 25 to 30 or more drinks per week. And we know that the recommended low risk drinking guidelines under 15 per week. So he gets an audit score, if we're formally scoring this through the audit process, of 9. So this puts him into a risk category around his alcohol use. So the question that I have is, with somebody who's got mild hypertension and who is drinking in the moderate risk category around alcohol use, how important is it that we might discuss alcohol with this person? So I looked a little bit to start with at what are the international recommendations about reducing hypertension in regard to alcohol. Some very clear NICE guidance. NICE recommends that we definitely ask about alcohol use and that we encourage reduction in intake if people do drink excessively, because this can reduce blood pressure and has other broader health benefits. So there's kind of NICE guidance that says, hey, look, this is something that that we definitely should be doing. In fact, it mentions that the evidence grade for screening and brief advice on hazardous and harmful drinking is high. So there's a lot of positive evidence that would support us looking at this. So let's have a little bit of a look at where some of this evidence came from. And it's been around now for a long time, since the mid-1970s in the US, the Kaiser Permanente study, which was a longitudinal study looking at a number of items in their multiphasic health examination screening that started around that time. And the conclusion there was that individuals drinking 6 to 8 drinks a day have about a 9mm higher mercury and about 5 to 6 millimeters higher diastolic and systolic values than non-drinkers. So there's a definite increase, sort of a 10/5 increase for people who are drinking 6 to 8 drinks a day. Now that is actually quite a lot. Obviously that's a person drinking 50 drinks a week, which is fairly high, but that was some of the original data that said there is clearly a relationship somehow between alcohol and hypertension. Some specific study that's been done with students. Students get these jobs. It's a study of binge drinking effects on blood pressure, and these were research weekends where there was a party weekend versus a sober weekend. And the students were given 10 to 14 standard drinks on the party weekend and no drinks on the sober weekend, and monitored for their blood pressure. And during the intoxication period, so that's during the time at which on the Saturday evening they were drinking 10 to 14 drinks, the mean systolic blood pressure was 5 millimeters higher, and the pulse was also faster compared with the corresponding sober period. So during the period of alcohol use, blood pressure is going up. Then during the period where alcohol levels were fallen, which was generally overnight, the blood pressure then dropped down to lower than the initial levels, about 5 millimeters lower. But in fact the pulse remained fast. So there's a period during heavy drinking where the blood pressure will go up, and then there's a period where it will go down, but it will actually go down to lower than the pre-intoxication levels. A very recent report has reviewed the data from the National Health and Nutrition Examination Study in the US. This is over 17,000 adults who have been enrolled there since the 1980s. And the classified people as never drinkers, 7 to 14 drinks per week, or 14 or more. So this is never drinkers having an average blood pressure around 109/67. So quite a low average blood pressure in people who never drink in this total adult population. For those that were drinking within low risk guidelines, the average blood pressure 130/80, a little bit under. And for those that were drinking above low risk guidelines, the actual mean blood pressure 153/82. So you can see a very clear correlation between alcohol consumption and in fact what blood pressure is. And this is a meta-analysis of 18 studies, over 300,000 participants, just really showing that there's a very direct relationship between the risk of hypertension and daily alcohol consumption. So it starts pretty much from 1 drink a day or 10 grams, and as the drinks go up, they're 25, 50, that's 2.5 to 5 drinks. There's a fairly initially linear relationship where risk of hypertension goes up in relationship to the dose of alcohol consumed, and that's maintained as the dose gets higher, although it flattens off a little. So there's a very clear correlation then between blood pressure and alcohol use, and the more a person drinks, the more likely their blood pressure is to be raised, and the higher it is likely to be. So if we look at the effect of reducing alcohol consumption, what actually happens? And there's been a large number of trials here also looking at the effect of reducing alcohol consumption on blood pressure. So if somebody's drinking 2 or fewer drinks a day, in fact, reducing their alcohol use is not particularly associated with a reduction in their blood pressure. So it's more if the people are drinking 2 or more drinks a day. So our patients that are drinking above low risk guidelines, that's above 14 to 15 drinks a day, then a reduction in the alcohol intake is associated with an increased blood pressure reduction. And perhaps somewhat as we would expect, in heavy drinkers, a reduction in systolic blood pressure and diastolic is much more marked. So those who drink 6 or more drinks a day, if they reduce their intake even by 50%, they will get reductions around 5 millimeters of mercury or in that kind of order. So there's a lot of evidence that reducing alcohol use will in fact reduce blood pressure. And this is a report of the actual mean reduction in blood pressure in over 1,300 people who were in a study for alcohol dependence. So these patients were admitted in the US for alcohol dependence treatment. So they were drinking up until the time of admission, then they were abstinent after admission. And over the first several weeks, the blood pressure drops quite significantly. So there's a mean reduction in the first month of treatment of 12/8 systolic over diastolic blood pressure within the first month. So you can see that for people who are drinking very heavily, even some reduction is useful. Abstinence can make a very big difference to their blood pressure, because that's obviously a blood pressure reduction that would be consistent with what we might achieve with a single medication. Interestingly, the blood pressure then does gradually go up again over time. So there's this increase in there's a reduction that happens in the first month or so, and then it goes up, but it stays well below the baseline level. So we clearly have a high amount of data. This is just a pictorial representation, not for reading, but just if everything that's on the left-hand side of the line on the left is about systolic reduction, and on the right is about diastolic reduction. And these are all the studies that show as you move towards the left of the midline there, the blood pressure is going down in association with alcohol reduction. So reducing the amount of alcohol in all of these studies moved blood pressure down on average between about 5 and 10 millimeters of mercury systolic and around 5, maybe even a little bit more diastolic. So we've got really a lot of evidence now that says management of alcohol is an important part of the management of hypertension. So what would we be doing here? What would I be saying to Mr. A? So I'd be saying something along the lines of an open question to start with. So this is the ORS thing. So starting with an open question. Do you know anything about the effect of alcohol on blood pressure? And I'd be kind of asking to see what the knowledge base was around that, and then working a little bit with the answer. Then I might say, would you be interested in some information? Because that would give me permission then to be able to provide a little bit of information around alcohol use and its effect. And I might say something like, look, here's some information. Cutting down on your drinking might reduce your blood pressure. You might need less medication. Is that something you would want to do? So I'm trying to give the control of these questions then back. I've made a suggestion, cutting down may be useful. Is that something you would like to do? And then that's giving something back to the patient to work with and gives them the capacity. Do they want to respond? And just on the basis of this kind of consultation alone and this very, very brief intervention, I would be expecting many people would listen to that and go away and think about that and would think, my doctor has said I need to be reducing my alcohol use and acting on that. So that's how we might look at alcohol and hypertension. Moving on to the second case. So Mrs. B, 52-year-old European woman with an appointment to see you made by the practice nurse after she scored positive on the PHQ-2 questions. So those are the two questions asking about depression, screening questions, while she was attending for cervical screening. And the nurse then went on and completed the full PHQ-9 and the GAD-7. And those scores show that here is a person who has got some degree of mental distress going on in their life. The nurse then also did a full wellness checklist of the person's non-smoking, but alcohol use was around about half a bottle of wine a night. So here's somebody who is obviously got concerns around their mood and well-being, and is using alcohol about half a bottle of wine each night. And what I was interested in looking at was what's going on here is that the alcohol that is contributing to the way in which this person is experiencing symptoms of depression, or is this person self-medicating because she is feeling low and feeling anxious and that makes her feel better? So I wanted to know the answers to those questions. Fortunately, there has been a very extensive review in New Zealand. It's very readily available, Alcohol and Mental Health, a review of evidence with particular focus on a report to inform the Mental Health and Addiction Inquiry in 2018. So a very recent comprehensive analysis. And in this review, it commented that people with mental health symptoms, if they are low-level drinkers, they are more likely to increase their alcohol intake. I mean, this is hardly surprising to us. We see this all the time. People who are distressed, they're more likely to drink more. And if they are already heavy drinkers, then they're going to sustain their high level of alcohol intake. So clearly, there's a lot of evidence around that there's a strong association between emotional and mental distress and mental health symptoms. The two really useful studies to look at in New Zealand are the Christchurch study and the Dunedin multidisciplinary study, have shown in the longitudinal review of the young people that have been followed up over many years that there were clearly significant associations between alcohol use disorders, so that's alcohol creating problems, and depression, anxiety disorders, bipolar disorder, and indeed attempted suicide. The review of all of this and the report for the New Zealand report for the Mental Health and Addiction Inquiry made the comment that it's very difficult to tease out the direction of the underlying cause and effect, and that it's still scientifically uncertain. And from my review of the literature, it seems that in some situations, it's clear that heavy alcohol use, in fact, has led to depression. And then in other situations, it's clear that people who are distressed and experiencing symptoms of depression or anxiety may be using alcohol in order to try and make themselves feel better. I mean, the commonest mental health issue associated with alcohol, of course, is alcohol use disorder per se. So that's where the alcohol is creating problems in and of itself, not necessarily in relationship to other mental health problems. And the latest classification of alcohol use disorder in the Diagnostic and Statistical Manual of the American Medical Association, the DSM-5, now classifies alcohol as a use disorder mild, moderate, and severe. So those are the criteria around whether a person is likely to be experiencing any dependence, whether they like to have cravings, whether their alcohol use is likely to increase, and so forth. And that's an upgrade from what we had before, which in fact was in the DSM-4 a way of understanding alcohol that is still very useful for us in terms of general practice, and that is that there are some people who use alcohol in a way that meets the criteria for alcohol abuse. So that is alcohol that is causing harm. Maybe causing harm to them physically, socially, occupationally, or relationally. So there are a number of areas in which the harm could occur, but they may or may not actually have alcohol dependence. And then there's a group of people, obviously, who have alcohol dependence, and these are the people who are likely to be gradually increasing alcohol use over time, need more and more alcohol in order to get the high, developing tolerance to it, have cravings and so forth if it's withdrawn. And clearly there's a bit of an overlap. In the DSM-5, it was felt that the overlap is very strong, and even many people who have harmful drinking will have some degrees of dependence, and so it's been combined into one. But I think from our viewpoint, it is helpful for us to think about alcohol in terms of the risk level associated with alcohol. People who are drinking above the low risk guidelines have got risk associated with it. Some of those people at risk are actually going to be developing harm. So those are the people that meet the criteria for alcohol abuse or harm. And then some of these people also are going to be developing dependence and are going to find it really difficult to change or reduce their alcohol. And it can be very useful for us to understand if somebody has got dependence, how difficult that might be for them. There's very strong evidence in primary care around screening and providing brief intervention, as I mentioned. So it's clear that we can address alcohol use disorder in a primary care setting, and we've got strong evidence around that. There's also a sort of an international call for us to have a bigger role in how we treat people with alcohol problems in primary care. I'm not really addressing that in particular tonight, but that may be the subject of another webinar, having a look at actually what do we do when we identify people with alcohol problems. So does treatment for alcohol problem improve mental health? And I think this is quite an important part of, we've got Mrs. B in here using alcohol, half a bottle of wine a night, which is therefore putting her alcohol use up at something around 20 to 25 drinks a week. If we address that, are we likely to improve her mental health? And in general, the literature supports that. The New Zealand report that we've talked about says that treatment and early intervention is important in addressing alcohol abuse and dependence, and the guidance around the Royal Australian New Zealand College of Psychiatrists is that before going on to treat mood disorders, it is very important to diagnose and manage any underlying alcohol use, because that may be clouding the management and the picture around mood disorders. So there's a kind of importance for us to be thinking about and addressing alcohol in that way. So what does that mean for us with Mrs. B? How would we go about bringing this into a consultation when she's essentially been sent to us because there are concerns around her depression? So I might say something like, look, thinking about the things that you're feeling, Mrs. B, I'm wondering about how, if it's okay if I ask you some questions around how you're feeling about your use of alcohol in relationship to that. And then I'd probably check out the information. Is it correct you're drinking half a bottle of wine most nights? Because, you know, clearly it could be more than that, and it would be good to give a person a second chance. Sometimes you might just ask an open question like, might there be occasions in which you would in fact finish off that bottle, or other occasions on which you would be drinking more than that? You might even say, many people who are drinking half a bottle of wine a night would on occasion drink a lot more than that. How often would you do that? Making that kind of assumption. And then maybe some just general questions like, how does that compare with your drinking before you started feeling down? Trying to get a sense then about whether this alcohol use has increased because of the depression, or whether this is a long-term alcohol use and maybe is contributing to the development of depression. Might want to know a little bit about what it is that's driving the use of alcohol. How does this wine make you feel? She describes this settles her anxiety, she feels better, she feels relaxed. So I would feed that back as a summary around or it's a reflective question, so it makes you feel a bit better. Can you tell me perhaps how it makes you feel in the morning? I would kind of just want to tease that out a little bit. And then I might want to just give some information. Do you know how alcohol can affect your mood? Are you aware of any information about that? I might ask permission. Can I share some information around what we know about how alcohol can affect you, how alcohol can affect your mood? And then if we did look at cutting down, could you do that? Quite an important question, because for many people they would say, well, actually I've tried and that is actually quite a difficult thing to do, and that's when you might want to explore a little bit more about whether there is dependence here, because if a person has dependency, it may be a lot more difficult for us to actually shift their drinking, and we may want support to be able to do this. Obviously, once you got into this conversation, we would be asking a lot more questions to understand about the impact of alcohol on her life, but this kind of questioning will get us very easily into the consultation. And even on the basis of this kind of questioning and a little bit of feedback and some empathic listening, for many people this will help change the way in which they're drinking. Then may well be in fact new knowledge and new information for them. So that's Mrs. B. Moving on to Mr. C, he's a 40-year-old Māori male, otherwise in good health. Apart from this presenting problem, he's got gout in his family history, and he presents with intense pain in his foot. This is the picture of it, and I think you'll agree that looks very painful. So that looks very much like gout. So on the assumption we've got that diagnosis correct, what do we know about the association of alcohol with gout? And how important is it to raise alcohol discussion for a person who's got gout? So we do know that in New Zealand there are genetic factors leading to gout as well, and that's important. But we do know also that alcohol is quite a significant issue. One study of a survey over 12 years looking at the relationship between alcohol consumption and the risk of incident gout, so that's the first risk of gout, and over 47,000 patients or 40,000 participants with no history of gout at baseline, showed a very clear relationship between the dose of alcohol and the type of alcohol. So the higher the intake, the more likely a person was in fact to develop gout. Beer conferred the highest risk, then spirits. In this particular study, they reported that moderate wine drinking did not increase the risk. But in other studies, wine has not been exempted, and it may well be that if a person actually has gout, then any alcohol is one of the things that may trigger. But as we know from clinical experience, beer is very commonly associated with the development of gout. And in fact, this is a slide that shows the risk ratio, or the likelihood that somebody was going to develop gout in over 700 participants. These are people with a gout history. They were followed up, and in relationship to the alcohol use, what was the likelihood that they would develop gout? And you can see that it rises very rapidly once you start drinking. Even in a couple of drinks, there is a likelihood of developing gout, but over 4 to 6 drinks it goes up very dramatically, and certainly above 6 drinks it's very, very high. So if somebody has got a gout history untreated, the likelihood is that they will develop gout in association with alcohol use. Many people will know how much alcohol they can use before they develop gout. So many people with gout who don't want to be treated know that they can have a couple of drinks and they won't develop gout, but above that they will, and they get obviously pretty quick biofeedback around that. But from our perspective, it's just helpful for us to know that there's a dose relationship clearly for people with gout and the impact of triggering further episodes. Interestingly, if a person was on a diuretic, that was associated with a much higher risk of recurrent attacks. So that's something that we need to be thinking about, that people who have got reasons for treatment with diuretics, say for example hypertension, we may potentially, if they have gout, lower the level at which alcohol use is likely to trigger gout. So allopurinol mitigated the effects of alcohol intake, as did colchicine to a lesser extent. So it's a little bit of opportunity here for us to perhaps negotiate that if people are wanting to have a couple of drinks, that they're less likely to get gout if they take their preventive medication, which is obviously a good thing for them to do. And interesting, non-steroidals don't actually modify the effects. So people who load up on non-steroidals to prevent gout and then drink are not likely to get much benefit, and in fact, of course, they may develop non-steroidal related harm from their alcohol use. So,
sorry, John.
yes,
Just if we could go back to the previous slide, if you don't mind. Just to two
this one here.
the next one from that.
So this way or the other way?
The one that talked about allopurinol and...
Oh, yes, there we go. Yes,
yep.
yes.
So 2 questions around that. What is the mechanism with the allopurinol that mitigates the effect of alcohol?
I suspect it's just that it actually has an effect on lowering the uric acid, okay, to make it less likely. But I'm not completely sure about that. There may be some competitive effect as well.
Mm-hmm. And what is it about beer that causes an increased risk of gout as opposed to other forms of alcohol like spirits and wine?
Yeah, so it's a really good question. So it's very clear that alcohol per se in any form does trigger, but there is something about the makeup of beer that acts as triggers as well, which I understand is to do with the metabolic breakdown products of the other items in beer that would contribute to purine breakdown and so forth. So there is both the alcohol content and something to do with the way in which beer is formulated.
Great, thank you.
So how would we address that? Assuming gout's the probable diagnosis, yes, this is likely to be gout. What do you know about it? I mean, people know a lot about alcohol and gout, obviously. Did you know that alcohol can be a cause for gout? So you've got an entry point here. Can you tell me about your own use of alcohol? So this is a really good opportunity to get into an alcohol conversation in a way that's very meaningful to people. What kind of brief intervention could we provide? Well, it sounds like your drinking could be causing the gout. What are your thoughts about this? So it's not straight in, you need to cut down on your alcohol use to prevent gout. That may be something that information we're going to do, but what we want to find out from an empathic sense to start with is, what are your thoughts about this? So it's inviting a response from the patient to know, because that person may well have a lot of knowledge already about the fact that alcohol causes gout, because they may have had actually personal experience around that. A really good question is, if you wanted to cut back on your drinking, how could you go about that? So it's kind of like one of those questions that puts it out there. I actually would like you to cut down on your drinking, but rather than me saying you should cut down on your drinking, I'm going to say, if you wanted to cut down on your drinking, how could you go about it? And it gives the person the responsibility of owning the problem and then starting to talk about what sorts of things that they might do. And a really useful question which comes through in the Tacky Tacky My framework a lot is, who could support you to achieve this? Because the change in alcohol use in somebody who's developing gout in say social drinking situations is quite significant. A person is likely not only have to reduce their alcohol intake, but they're probably going to have to change the way in which they drink. It may impact on the way in which they interact socially. So it's not really a simple thing that we're encouraging people to do. It can be quite complex, and finding out who sits with that person, who supports them, who stands with them, who they can get to support them to achieve that can be a very useful way of getting some kind of support. So these kind of open questions, can you tell me about the use? What are your thoughts about this? Who could support you? These are really good ways of just teasing up and opening up the conversation around alcohol and, in this case, gout. And even in this kind of discussion, in the clinical context, this is likely to have some positive impact on that person's response.
John, when you talk about asking a patient how would they go about, or what would their thoughts be with regards to techniques or tips and cutting down, sometimes when we open up questions like that, we find that because we are putting the ownership back on them, that it's actually quite a hard one for them to answer. Do you have any tips or tricks in terms of nudge points or gentle direction or other ways that you can open up that conversation where you can just give them a little bit of guidance and support around that?
Yes, I know it can be very tricky when you think you've asked a good question like, have you got any ideas about how you'll go about that? And they just look at you straight and say, no, John, I don't. Yes, so that can be quite tricky. So I think the response to that is, I like to think of two kinds of responses. The first is, who else would be interested in this issue for you, and what sorts of things might they be saying, and what sorts of things might they suggest? Because it is extremely likely, if somebody is drinking in a way that is triggering health issues, somebody has already talked about it in the family with them. And so that voice, the silent voice that's present in the consulting room but there's no person there, is a very powerful person to bring into the consultation. So I would often say, who else would know about this? Who might have comments? What would somebody else in your family, or who is significant to you, what would they say? Trying to get them to own and be the voice for another person, because it's always more powerful if it comes from them. If I can't get anywhere with that, then I move to, can I share with you some ideas that other people have told me?
Okay.
So then I might say, what would be an issue for you if I was to suggest that you need to cut down on alcohol use? What would be the problem? And people would come back and say, well, I'd lose all my friends, or I like going out on Friday night. It's my release at the end of the week. It's having a great time. Oh, okay, I hear that. Other people have told me the same things. This is some of the things that other people have told me that they can do. They can still go out, but they look at other forms of alcohol, in other words, other forms of drinking. So they might look, for example, at spacing out their drinks by using non-alcoholic drinks, or they might tell the people they're going out with that they're off alcohol at this stage for whatever reason they want to say, and ask for their support around that. Or they might look for some alternative social situation in which they can still meet with their friends, but alcohol is not primarily involved. And I might kind of tailor that to the person in front of me and bring out some kinds of suggestions around what might be there. The whole idea being that you want to put ideas out there in a way that can't be knocked back, but are just there for consideration. Because even though people say, I don't have any ideas, they do have ideas.
Yeah.
It's just they're not willing to share them right at this point in time.
Fair enough.
Yeah.
Thank you.
So going on to Mrs. D, who's 68-year-old woman in for a routine review, and this looks like a fairly typical general practice patient. She's got type 2 diabetes. She's on metformin and glibenclamide. She's got hypertension on metoprolol. She's got mild hip and knee arthritis on regular paracetamol. And she's using Zopiclone 2 to 4 times a week to help her sleep, because she's concerned about the pain that she's got. So the questions that I want to know here is, what do I need to do in relationship to bringing alcohol into this picture? Is it important or not? If I ask her alcohol questions and find that alcohol use is that she is drinking regularly, particularly if she looks like she's drinking above low risk guidelines, do I have to have any concerns around this? So this is a really hard one, because the information around that's actually really strongly evidence-based and reliable around the relationship between alcohol and medications is quite difficult to find. And there is a lack of consensus about actually what constitutes an alcohol interactive medication. So the study that I found that I thought was most helpful is a study that is looking at potentially serious alcohol medication interactions in older adults. It's called the Possomino study, based on the acronym there. And this is a study coming out of the UK, which used a panel of expert process reviewing literature and guidelines, and then going through what's called a Delphi process, which is looking at a weighting of responses for each medication against the likelihood that they're going to cause problems, essentially a sort of expertise consensus approach. And this group have come up with a number of medication classes which we need to be thinking about when we are prescribing, because there may be a relationship with alcohol in this. And the criteria that they have defined has been used in one study so far to look at, is it predictive for falls? So in the study, which has been reported just this year, older adults using alcohol interactive medications did have an increased risk of falls. So they're looking for some validation around what has been a consensus process, trying to get a very strong evidence-based process about it. And they've come up with a 38-item criteria, but it breaks down into really a very small set of medications, and these are not that different from medications that we would be thinking ourselves, I need to think about alcohol in regard. So there were no major surprises. The second biggest group and the first group was cardiovascular system medications, essentially ones that might have an effect on exaggerating the effect of lowering blood pressure. So most of the side effects to do with cardiovascular system medications are to do with exaggerating hypotensive effect. The respiratory system relates really just to first generation antihistamines such as promethazine, which we are using much less. Very occasionally we'd use that, and there's obviously a risk of sedation. The biggest group, in fact, was the central nervous system medications. There were 15 types of medication in that group, and all of these, the concerns were that there was increased CNS depression and sedation. And so these are all the medications that we would be thinking about. If a medication affects the central nervous system, it is likely that alcohol is going to enhance its sedation type side effects. Around diabetes, there are medications. The main concern there around alcohol is that in fact it will impact on and increase the risk of hypoglycemia. And the ones around musculoskeletal and joint diseases are primarily around the risk of bleeds. A little bit around sedation, but mainly around bleeding risk. And then there's the one that we commonly will know about, infections, particularly with metronidazole, which are reported to cause a disulfiram-like effect. There's a lot of debate in the literature about how true this is. The impact of metronidazole causing a disulfiram effect is widely understood, and certainly it is pretty common for us to be warning our patients on metronidazole that if you drink alcohol, you are likely to experience flushing and other symptoms of unwellness, nausea, and so forth. But in fact, it's been quite widely challenged in the literature, and I think the jury's still out about whether the effects that have been traditionally reported to do with metronidazole are related to, in fact, the case studies where alcohol was being consumed in heavy amounts, or whether in fact it is the medication. I wouldn't be changing the advice at this stage, but I think it is something that we need to think about. And then the last category was around malignant immunosuppression drugs, which are not drugs that we are actually using in general practice in New Zealand. So if we go back to our patient, Mrs. D, so here's a patient that we've got on metformin. What's our concern? And basically, the concern around metformin use is primarily around the risk of lactic acidosis, to a lesser extent around the risk of hypoglycemia. But this patient's also on sulfonylureas, and alcohol consumption can obviously enhance the hypoglycemic effect of antidiabetics. So we would be wanting to at least bring alcohol into the discussion around the diabetes management in regard to the medications. More so in regard to the medications than in regard to the diabetes process per se, because in fact people who use alcohol on a regular basis may in fact be at a slightly lower risk for developing diabetes. But once they have the condition, the treatment with medications may be interactive with alcohol. In the posamino group, heavy alcohol consumption is relevant with multiple antihypertensive combinations. So our patient's only on metoprolol, one medication. So therefore, there is a risk around alcohol consumption potentially increasing a lowering blood pressure effect and exaggerating that. But on a beta blocker, that is unlikely to be that powerful. So it's something that we might want to discuss, but we wouldn't be overly concerned in that regard. The one around heavy alcohol consumption and long-term regular paracetamol. So here we've got somebody who's using regular paracetamol for arthritis, which would be quite common. If this person is drinking alcohol in a regular and heavy consumption, there is some risk, obviously, around hepatotoxicity, but it's really interesting in that it seems quite complex, and the risk seems to be most marked if alcohol intake is abruptly stopped. And that has something to do with the fact that paracetamol and alcohol have their various metabolic processes, but one of the metabolic processes is via cytochrome P450, and there may be some competition between them. And then if alcohol intake is abruptly stopped, the paracetamol then actually has a much more marked effect on the liver. It's called the alcohol paracetamol syndrome. Very good write-up in New Zealand Medical Journal about that, and I've put the reference in here. So really, it's more of a caution around the use of paracetamol in people who are using alcohol in a heavy way. And then the last one is this patient is taking zopiclone for sleeping. So heavy alcohol consumption with benzodiazepines and other related medications That's part of the CNS sedation effect, and clearly it's going to enhance CNS depressant effects. So for this patient, we've probably got, if the person is drinking some alcohol within low risk guidelines, we've probably got very modest likelihood of an interaction, but we've got 4 agents or 5 agents that she's being used that potentially could interact. So they add together, and there is some risk here around alcohol use. If this person is in fact drinking on a regular heavy basis, say they were drinking 30 plus drinks a week, then each of these medications would carry some risk, and there is a much more increased risk that this person is going to experience adverse effects from that combination, and we would certainly be wanting to bring that into the discussion. One of the ways that I find really useful to bring this into the discussion is to use the patient information pamphlet. So I've looked specifically at the patient information pamphlets that we've got available through our New Zealand systems. For metformin, it specifically says if you use alcohol, there is a risk of developing lactic acidosis. So that's something that we could raise as a little bit of information for a person when we have that leaflet available. We open it up on our computer to share. On glibenclamide, it just says if you drink alcohol, especially in combination with skipping meals, there is a risk of hypoglycemia. So again, pamphlets are a really good way of saying, hey, here's some information. What do you make of this? Is this something that is likely to be relevant to you? The information on metoprolol says, be careful drinking alcohol while you're taking metoprolol. Dizziness or lightheadedness may be made worse. And with zopiclone, it says alcohol should not be consumed when taking zopiclone tablets, as the sedating effects may be increased. So there's a comment really on all of these ones, and then around paracetamol, they've really hedged their bets with the paracetamol tablet leaflet and said, taking paracetamol with alcohol, you should not drink while taking these tablets because alcohol and paracetamol can increase your chances of side effects. Actually, that's quite a good way of saying it because it's quite a complex thing, I think, to have to explain in any case. So you can see that all of these medications have got really quite a good way. I mean, you can have this discussion with somebody and say, are you aware of the relationship between metformin and alcohol, or glibenclamide and alcohol? Or you could say something like, has your pharmacist ever included a label on your medications advising you to be cautious about alcohol with any of these medications? So those are all really useful entry points, but I think sometimes the printout of a pamphlet just gives you that little edge because it's there in black and white, and you can say, here's some information, what do you make of that? Is this something that we need to be talking about with you? So kind of going into the opportunity for a discussion by asking 1 or 2 open questions. And really just to comment that the other common medications not present in the case we've just discussed, but in relationship to the Possomino study, ask about alcohol with opioids, obviously, with antipsychotics, with anticonvulsants, tricyclic antidepressants, mirtazapine, which I'm seeing prescribed quite a lot more, and also gabapentin as well. So all CNS medications, really, one of the things that we need to think about is if this medication by its nature may have sedating side effects, then if alcohol is brought into the picture, then that is obviously going to be very much more sedating. And another really useful opportunity to raise this, of course, is around driving medicals and so forth, because impairment of function is very likely to occur in relationship to the use of medications and alcohol use. And interesting to just go back to the original study that looked at what happened to the party goers who were intoxicated, that their blood pressures went up during that period of intoxication, then went down more markedly than normal, than below their normal blood pressure. And so that may potentially be going on with people who are on antihypertensives as well. So if people are taking their medications in the evening, are drinking in the evening, then overnight they may potentially be having quite significant hypotension, which would not be present in the evening while they were drinking, might not be present the next day when you saw them, but could put them at risk overnight of having quite low blood pressure and potentially increasing the risk of ischemic stroke in that scenario. So I think for the medications, we've got lots of opportunities, but for us, first of all, it's really just to be aware of those classes. Mainly cardiovascular and CNS medications are the ones that we would be commonly prescribing along with the diabetes ones, to think, have we asked about alcohol in relationship to these medications? And then what's the entry point for that discussion? Use the pamphlet, or has the pharmacist discussed this, or are you aware of the potential for these interactions? And really just want to finish off with just a reminder about the recommendations for low risk drinking. So low risk drinking guidelines are for the population. If someone is on medication, or if someone has these conditions that we've talked about, then that's not necessarily the same guidance as you would give for a general population. So in the general population, we're really saying that on any one occasion, 2 for women, 3 for men standard drinks, no more than 10 or 15 a week with a couple of alcohol-free days. On any single occasion when a person might be drinking more, no more than 4 or 5. None at all when a person is pregnant, or when a woman is pregnant. So that's fine, but remember that if someone has a health condition that is impacting on their wellness already, then in fact even these levels are likely to increase risk. So if somebody is drinking at 14 drinks a week, which may be just within the low risk guidelines, but they have a health condition that places them at extra risk, in fact, these people may be drinking in a way that is actually quite risky for them, and that needs to be brought into the consultation and have further discussion. So Grace, that's basically the presentation. Very open to any questions and any comments that anybody would like to make.
Sure. I really like your last point with regards to that awareness that we need to have about not just looking at general sort of standard drinks and how that means with the population, but tailoring it for the person that's in front of us. So that's good to be aware of. I do have a question that's come through with regards to paracetamol. Someone's wondering, is hepatotoxicity, sorry about that, is that an issue even when we use normal doses of paracetamol with these?
Yes, well, it does seem to be. So it does not seem to be too much a risk in very short-term use, but for people who are using even therapeutic doses on a long-term basis, then there is potential for interaction with alcohol. And in fact, in the New Zealand Medical Journal paper that I quote in here, which has looked at that process and reported on the alcohol paracetamol syndrome, one of the cases that were discussed, that person was on therapeutic doses of paracetamol and yet in fact had quite marked hepatotoxicity. But that was a person dependent on alcohol, so it was a heavy drinker, and so high use of alcohol, average use of or therapeutic use of paracetamol. There was significant issues around hepatotoxicity, and then when the alcohol was stopped, the hepatotoxic effects were markedly increased over the next 48 hours. So that person's transaminases shot up from an increased level to an extremely high level, and obviously we're very much putting them at risk in that we're in an intensive care unit. So there's clearly going to have to be a judgment for an individual around what is the safe level of paracetamol use and alcohol use, because it's largely heavy alcohol use associated with therapeutic paracetamol use on a long-term basis. There is significant risk there. If the alcohol use is lower, and so in the low risk within the low risk guidelines, and the paracetamol use is not necessarily regular, then the risk is very low. In between times, then that might be just something that you would have to monitor and decide on a clinical basis.
So would considering things like having paracetamol-free days, or even looking at potentially monitoring with LFTs and things, do they have a role to play in this particular circumstance?
Well, I think there really is a lot of clinical judgment around that, and in the discussions, and in a sense thinking about the potential for change talk here, these are really useful discussions to have, because one of the things that we'd be wanting to know is alcohol being used here in a sense partly to try and manage pain? And so that's quite a good entry point into the process, and teasing out the pain, the alcohol use, the way in which alcohol is being used, and what other kind of background issues go around that may yield quite a different clinical insight into this person. So certainly we're all going to have patients who have got arthritis that is not at a point where surgical intervention is appropriate or desirable, who only want to take paracetamol to treat that, and who want to use some alcohol, and by and large that is going to be fairly low risk activity. But when we've got somebody that we're using it on a regular basis, we may well want to think, would it be helpful to have some paracetamol-free days? In fact, does this person need this dose of paracetamol? Or in fact, could we be looking with this person at reducing their overall alcohol use?
Okay. Now, you used an interesting tool with regards to bringing up the patient pamphlets as a way of entering into a discussion or drawing in alcohol and medication into that discussion. I do wonder whether or not, in your experience, if you've found that you have to phrase things quite carefully around medication and its potential effects on alcohol with regards to decreasing potentially compliance of using the medication. Has that ever been an issue for you? So people having
look, I very much agree. How we have this conversation is critically important, and the purpose of raising it on the pamphlet is that it can be a very comfortable entry point, because if you like, a pamphlet is an external item sort of saying alcohol seems to be something we should be talking about, can we talk about that, with the focus on the alcohol use rather than on them not taking the medication, obviously. So yes, can it be a problem? It potentially could be, but I don't think it will be a problem if we go into it in a way that starts by using open questions, by hearing what the person has got to say, by teasing out a little bit about what their alcohol use is, and then in the end, if in fact somebody is using alcohol on a basis that might put them at risk, first of all, that's really important information for us to know about. Secondly, we may want to modify how we are using the medication in the light of that information. And thirdly, it's really about negotiating with that person around what is it that we need to be doing here. I'm concerned about prescribing a medication that potentially could be harmful to you if you are drinking in this way. What is your response to that information? Trying to tease out how important alcohol use is for them, where do they want to go. So I don't think it's an issue in practice, unless they go away with the message that says, my doctor told me I should stop the pill so I can stay drinking, and that's probably not the message we're trying to get across.
Fair point, fair point. Well, thank you very much, John. Oh, look, sorry, we've got just one last question as I turn my gaze to the left. Someone's just asking a question about alcohol. I think this is the question, and if the person wants to clarify a little bit more if I don't get this right the first time. Are there any potential effects with the use of alcohol and melatonin?
It's a really good question. I would have to look that up to know. So to find out the answers to these other issues here, I did quite a lot of evidence research to find out actually how good is the evidence around that, because it is actually quite difficult sometimes to find good solid evidence around whether alcohol is impacting on conditions. And I must say, I thought alcohol would be very likely to be having a negative effect around diabetes, and was surprised to find, in fact, at a sort of epidemiological level, a use of alcohol can have a positive effect on prevention of diabetes. Once you've got it, it's a different story, obviously. And there are other factors around diabetes to do, of course, with alcohol in terms of its weight gain and so forth, even compliance around medication, which I haven't really talked about. So for melatonin, that would be a look-up question. I mean, that would be something that you could look for the evidence around. Very likely, the standard references would help clarify if that is the case. I guess, you know, you might loosely class melatonin within the CNS group. It's not listed in the POS amino list, so not specifically there. So if somebody was taking melatonin for sleep and was using alcohol, I would probably do a quick literature review to see, but I would be surprised if that was something that was likely to be of major concern.
Okay, great. Well, thank you very much for coming on board and talking to us about this very important topic. I was quite surprised myself, and sort of learning how alcohol can impact on so many different areas of our body, and just it's really nice having that awareness, just being a bit more mindful about our elderly patients and how we should be approaching them, particularly with your last point with regards to discussing those standard drinks and just being really mindful in how we tailor that for our individuals in front of us. So
thanks, Grace, and a very strong recommendation to all our participants that have a go with this conversation. If you ask open questions around alcohol use, you generally speaking will enter into a discussion where people, you and the patient will be very comfortable with that.
And I suppose as primary healthcare practitioners, one of the advantages that we have is that we form relationships with our cohort or the people that we treat, therefore we're in a prime position to engage in that sort of conversation.
That's absolutely true. It's a hugely therapeutic benefit just from that conversation alone, and our words carry a lot of power, which is great, and our capacity to achieve change for our patients is very high, and often with very little conversation. It's the style of conversation and that empathic approach that is the core of general practice, and which is the core of any kind of change talk.
That's right. Thank you. Just to let everyone know that a copy of this talk will be available on our website in the not too distant future, along with any relevant resources. And our next webinar will be on the 5th of November. We'll be talking about managing atrial fibrillation in primary care. So thank you very much, everyone, for joining us tonight. Good night.